Welcome to the January SSAT Resident Corner. Today we'll be talking to Dr. Mark Katlic, who is the chairman and the surgery-in-chief at Sinai Hospital and LifeBridge Health. My name is Vanita Ahuja, and I'm a general surgeon and residency surgery program director at Sinai Hospital in Baltimore. Dr. Mark Katlic had an unusual career path, and today we'll take a time to learn a little bit about his life. Dr. Katlic graduated from undergrad at Washington Jefferson in Pennsylvania, and then he went to medical school at Johns Hopkins University in Baltimore. He went to Boston to do his surgery residency and cardiothoracic fellowship at Massachusetts General Hospital in Boston. After completing his fellowship, he took an unusual path and joined private practice in northeastern Pennsylvania, where he had a successful private practice for the next 20 years, and then came back to academic surgery over the last 15 years and has been doing very successful to become the director of the geriatric program and the aging surgeon program, and now he's a chairman and surgeon-in-chief at LifeBridge Health Sinai Hospital. Welcome, Dr. Katlic. Thank you for joining us today. So the field of geriatric surgery essentially did not exist before your 1990 book. Your aging surgeon program is also unique to the world of surgery. And you have done more video-assisted thoracic surgery under local anesthesia than just anybody in the world. So you've taken this amazing career and had an unusual path to success. What helpful hints can you give to our residents about innovation in surgery and future planning?
Well, I think everyone needs to maintain that sense of curiosity and an open mind. You know, not everything has been invented yet. And you don't have to be in a major academic institution in order to make a contribution in surgery. You know, my whole career in geriatric surgery came about when I was a resident. You know, I was a senior resident at the Massachusetts General Hospital, cared for a couple 100-year-old patients. They were delightful people, and I went to the record room, looked up everyone who'd had surgery over 100 during some time period. There were 6 of them. They all survived surgery. And so I wrote a small paper called Surgery in Centenarians, and it changed my career. I was a solo author. I was naive. I submitted it to the Journal of the AMA, and it got accepted. It was noticed by a book publisher who thought maybe we need a book on surgery in the elderly. There wasn't anything, and so one thing led to another. And in 1990, I published my first book. And so there I just fell into a field, a hole that existed where really no one else was writing about it or speaking about it. And that was purely just for sort of following my curiosity. That paper was of no medical importance whatsoever. I just speculated that by the time one reached 100, he or she had been tested by life and might be more fit than his sons and daughters. But in any case, just following my curiosity, basically, led to this interest in geriatric surgery. And now, we're working with the American College of Surgeons to set standards for the country on geriatric surgery. And I'm working on my 6th and 7th book, actually. And that all began when I was a resident and just kind of followed my curiosity. Now, you do need to have a little bit of confidence in yourself and a little bit of persistence, but again, you don't really need to be in the lab to make contributions also. The video-assisted chest surgery under local anesthesia and sedation began just out of clinical practice when I cared for some very sick patients who had large pleural effusions or early empyemas, and I just didn't want to put them to sleep and intubate them. And so I began doing those under local anesthesia, and then I found if you could make 1 port, you could make 2 ports, and if you made 2 ports, you could make 3 ports. And so I began doing lung biopsies and pericardial window procedures and other procedures under local anesthesia and sedation also. So that's a case where that also just evolved out of clinical practice and sort of maybe pushing things a little bit, to make it happen. I think it also speaks to the importance of so-called eureka moments in medicine. These aha moments when a light bulb goes off. And I think that's what helps keep you going in medicine. There's plenty of drudgery and there's plenty of frustrations, but when you get that jolt of lightning, either with an individual patient or with sort of a concept or thought about a new operation, that's what keeps us going. And I tell the medical students, you may be doing the most complete exam on that patient in the hospital of anybody. And I've had medical students detect thyroid nodules that had previously been undetected, melanomas that had been undetected, and so there an individual patient's life is changed by something that a medical student discovered. And similarly, those eureka moments that lead to contributions can be important too. And it's those types of things, I think, that kind of keep you going over a long career of doing a lot of the same thing most of the time.
So, Dr. Katlic, you had mentioned about the aging surgeon program. Would you mind telling us how did you get into that, and what do you think is the future of the aging surgeon program?
Well, our aging surgeon program is the other side of the coin to some of the aging patient issues. 20 years ago, a work group for the American College of Surgeons recommended that there should be an objective evaluation of an aging surgeon's physical and cognitive skills, but nothing was ever done. It just was completely dropped, and somehow I noticed a reference to that several years ago and realized that we just didn't have any such objective evaluation of an older surgeon's faculties or a surgeon returning from illness. And so I convened a group here in my office of neurologists and neuropsychologists and lawyers and nurses and occupational medicine folks. And over about a year, we built our aging surgeon program, which is a 2-day comprehensive evaluation of an aging surgeon's physical and cognitive faculties. And so now one exists, and it's sort of elevated the national discussion about aging surgeons, which is controversial and laden with emotion. But again, I think it was just one of those things where the idea popped into my head. No one had done it, and so why not do it? Maybe it speaks again to that confidence that you can do something, if you want to.
So, just going back to your life 20 years ago, you have had an illustrative career. You trained in Massachusetts, did your general surgery and then your CT surgery fellowship, and then you decided to join private practice in rural Pennsylvania. Can you walk me through that decision making and your unusual career path?
Well, I opted really for the independence of private practice. I had enough other interests that I didn't really want to be, I guess, forced into a particular mold. I didn't want to be forced to do research in order to advance my career. If I did research, I wanted to do it because I enjoyed doing it. And so, yes, I went straight from very academic training at Hopkins and the MGH right into private practice in northeastern Pennsylvania, and had an opportunity to practice general surgery and general thoracic surgery, which was a wonderful broad practice that I think many people today might envy. And over the last 10 years, I've really limited myself to general thoracic surgery, but it was a nice practice at the time. I think it's important not to look down on private practice. I think in major academic institutions, there's that tendency to look down on private practice. But I can tell you, there's a great deal of satisfaction in just taking good care of patients. And I think I had some of the best results of my career when I was in private practice. You're doing all the cases yourself. Every stitch is where you want it to be. The cases tend to go quickly, and for example, I did a lot of esophageal surgery in private practice. I didn't have a death or anastomotic leak from esophagectomy in my first 15 years of practice. And was doing these cases in relatively small hospitals. So it is possible to get great satisfaction and to get excellent results in private practice. Now, I think academic research and even bench research is laudable, and huge advances are made that way, but it's not for everybody. The other point I should make is that one's career is not set in stone. And so I actually started out in private practice and then became more academic and then became more academic. Some people go the other direction. But, it's necessary for every surgeon to reinvent him or herself during their career anyway. I didn't learn, I learned laparoscopy and video-assisted chest surgery after I was in private practice. Subsequently have learned endobronchial ultrasound and laser bronchoscopy and now navigational bronchoscopy. And so, we all have to learn new things. We're constantly learning and thereby potentially reinventing ourselves anyway. So I wouldn't look down on private practice, and also realize that one's career is not set in stone anyway.
So you've had a busy surgical career. You've been busy teaching residents and medical students and speaking around the world, and also a surgery chair and a busy clinician. How do you find time for hobbies?
It's very difficult to find the time, but I would strongly encourage residents and students to develop hobbies and outside interests early on and push to continue them. We've learned with the Aging Surgeon Program, one of the barriers to surgeons retiring at a reasonable age is that they don't have anything to do outside of the hospital or outside of the OR. And if one develops hobbies and outside interests early, then that becomes much less of a problem. And so I got into doing triathlons through swimming and endurance things, and I have to carve out time very early in the morning to do some exercise, because that's the only predictable time during the day. But it's important enough to me that I get up early and get some time in early in the morning. But whether it's that or some other activity, I'd strongly encourage residents to do that. I think our residents do have more outside interests than many of the more senior surgeons who, first of all, put in more hours during training and had little time, but then have continued that in their careers. And they enjoy operating so much that it's very hard to get them out of the operating room, actually. So that, and I love to read, and I play a number of musical instruments, and none of them well, but I can do them at home in the privacy of my own house.
So thank you, Dr. Katlic, for joining. But before we end, this is the trickiest question you're going to get. If you were not a surgeon, what would you choose?
I probably would be a professor of English literature and write novels.
Wow. What is your favorite book?
Oh, I read everything. I read everything. I grew up reading science fiction, but I read biographies and mysteries and science fiction and almost anything I can get my hands on.
Yeah, many may not know, but Dr. Katlic is a medical history buff, and he makes sure he always educates our residents. But thank you, Dr. Katlic, for joining us, and it's been a pleasure talking to you.
My pleasure. Thank you.